Thank you so much for staying with us. Welcome back. You're watching Morning Cafe. It's Health Thursday, and this morning we want to focus on Chronic Disease Awareness Day. This is not a day globally recognized yet, but of course other countries are celebrating this day on different months, others in April, others in June, Kenya, July, but we'll be finding out why is ours set for July. And of course, today we are shining the spotlight on the growing burden on chronic illnesses in Kenya. What are they? What's driving the numbers, the increasing numbers of chronic illnesses in the country? And what do we need to shift in regards to our healthcare system? And of course, personal lifestyle. Joining me for this conversation is Monica Wanjiru, a general practitioner at Maya Kidney and Health Hospital. Karibu sana, Daktari.
Thank you so much for having me.
Good to have you again. So let's start with the basics. You know, we're talking about chronic illnesses, but usually this is not something that we talk much about. Mm-hmm. What are they and how different are they from, you know, when you talk about malaria, mm-hmm. homa, say typhoid, how different are they?
So when you talk about chronic disease, it's something that has been there, but generally the burden more was on infectious diseases that you've mentioned, the typhoid, the malaria, and all that. Mm-hmm. But we've seen the rise in chronic diseases. Mm-hmm. And just to start with the simple explanation of what chronic disease is, it's something that is persistent for more than 3 months, and there's no cure for it. So we're seeing an increasing burden. Of course, we're going to mention a few things that have caused the rise of the conditions, and then that's why we're putting a lot of emphasis, because we're seeing more increase in turnout in the hospitals, complication and all that, and decreased quality of life because of such conditions. Mm-hmm. Yeah.
So when you talk about you're seeing increasing numbers in hospitals, mm-hmm. and I know the NSDs, that is the non-communicable diseases, mm-hmm. Now cause around 27% of deaths in Kenya, and of course occupy nearly half of hospital beds, like you mentioned. Mm-hmm. So what does this mean for everyday, you know, people seeking healthcare in these mm-hmm. health facilities, and what's driving the rise in these numbers?
So we can start first with what is causing the increase right now, mm-hmm. because we're seeing a change in lifestyle, of course. Mm. Starting with simple things, what you eat is what you are. So mostly diet is what is affecting us. And of course, the increase in urbanization, how you've seen a shift in diet as compared to people in the rural areas. So we're seeing a more increase in the urban setup and like in the rural setup. We have also seen, basically in the rural areas, people are physically active. Either they're in the shamba, they're doing something, actually they're active. But in the urban sector, we're seeing a lot of sedentary lifestyle that is also driving the increase. Mm-hmm. There is also our recreatory behaviors. Mm-hmm. Before we used to go to the field, run, go see a match or something. Mm-hmm. Nowadays, people are either going to clubs, having a drinks out there. Smoking is also in the increase, and this mostly it was more gender related, because men were doing more of the recreation drugs. Right now, everybody is doing it, even women and even children below the age of 18, which is also affecting our metabolism and causing the increase. There's also environmental hazards. There's industrialization. There's chemicals that are in the air. So those are just among the few basic things that are causing the rise in the burden. So this also has caused an increase in the healthcare system, increasing the burden. Unlike before, you find most of the people in the outpatient will be coming for simple ailments like respiratory issues, which are the leading cause of most of the acute outpatient cases. Mm-hmm. Nowadays, you're seeing that it has gotten to a point that the hospital is setting aside a segment for chronic care management, mm-hmm. to manage the diseases. And you find, especially if you worked in public sectors, you find there are different days for those clinics. There's, for example, I used to work, there's Monday from MOPC, that is medical. There's surgical, there's all those. So you're seeing that it's a need, there's a need to put more focus on this, mm-hmm. especially on the prevention side, to see how we can be able to calm this down. And the problem is, mm-hmm. chronic disease starts as one, mm-hmm. and they always they always find a way to bring others on board. For example, we start with simple hypertension, but we later progress either to kidney issues, heart issues, mostly because of control, follow-ups, and monitoring. Yeah.
So can someone look extremely healthy and also have these signs of, developing conditions? Like you say that sometimes, it starts slowly. So can one be extremely healthy, but say they have this a chronic illness that is just developing slowly and slowly?
Surprisingly, yes, because most of these findings are incidental. And for those who are brought in the hospital at the later stages, we are talking about end progression. We're talking about that stage for those that are classified. But surprisingly, most of these cases, we're finding them when we're doing the wellness checkups. I'm sure you've seen around that there are several medical camps, either led by the government, led by NGOs, and also private hospitals as well that are free. Most of the people, I hear them saying, "What I don't know would kill me," so they don't want to find out. But you find a healthy person physically looking at them, but you find actually the pressures or the sugars are on the roof. They're basic things, and I think because most NCDs are not dramatic when they're starting, and when you talk about infectious diseases, the symptoms are just out there to ignore. Most of these chronic diseases, the symptoms are very subtle, and most of the time, barely no symptoms at all. For example, for hypertension, I can say for every group of wellness that I do, I find more than 10% have issues that we have to address. And they'll tell you, I've not had any issues. I've been okay, I've been normal, I'm doing my work. So they don't see the need, in as much as you found out, they don't see the need for follow-up or any changes after that. And that's why the awareness, education is very important as to why, yes, I'll start, mostly we start with lifestyle changes before we go to medication therapy. Yeah.
So when a patient comes, of course, to the hospital, and they're presenting different signs, and they're saying they're feeling pain in one area or the other, what exactly are you always testing to see? If you say that, chronic illnesses can vary from one to another, but what exactly are you testing for?
So it's not, we don't have a template for all of them because there are a number of them. We start with the leading, that is hypertension. We go to diabetes, that takes the huge burden. We go to cancers, we go to thyroid issues, heart issues, kidney issues. So we start with the basic, and that's how we start with triage. Every time you come to a hospital, we start with triage. That's how we can tell how your pressure is. Simple blood pressure testing, simple sugar testing. Those are tests that you can get even from a pharmacy at a price of 100 shillings. There's a urine test which can tell us how your kidneys are doing. And mostly, to put emphasis on these, the annual checkup is very important because that's how we pick some of these cases. And we pick some of these subtle symptoms, like somebody, for example, for cancer. Cancer is so notorious that is mostly diagnosed at a later stage because the symptoms are not so pronounced, and the symptoms are not so, they're not specific for you to tell that this is what the patient is suffering from. So unless you have a doctor who has a very, very high index of suspicion to think, you'll be coming over and over because of stomach issues, you're here, you're there, and then they'll start thinking colon, gastritis, and all that. And some of these, they are the basic tests that we do that we can find out, but mostly for cancers you find the diagnostic tests are quite expensive. For example, for cancer, if I tell you you need an endoscopy with a histology, we're talking like more than 15,000 in terms of money. So economic-wise, and also how the patient is in terms of their pocket also affects how fast they're gonna act to maybe catch some of this and reverse or maybe stall the progression. Yeah.
So what happens to that patient who comes to the hospital? You're talking about maybe 15,000 for testing for endoscopy. But what happens to that person who cannot really afford that kind of medication? But they have to do this checkup, they're presenting signs of, say, a cancer that you are looking for. But what happens if they can't afford it?
That is tricky because now it trickles down to the different, of course, looking at chronic disease, we're looking at every partnership, that is the NGOs, the public hospitals, and also the private hospitals. It's not possible to say that we can waive off everything, but most of the time we find patients go to an extent of even trying to fundraise to get some of these funds, or either the hospital maybe does a waivering for some of the tests, or maybe they can maybe reduce the cost, and also the SHA also helps in terms of sharing costs with the public insurances to ensure that some of these very expensive tests are split, the bill is split between the public and the private health sector, or maybe the patient chips in from their own pocket. But we've seen actually that is a major problem, especially financially, for patients to be able to afford treatment. And sometimes, especially in cancer cases, they stall the treatment to a point that you got it at an early stage of maybe stage 1, stage 2, where you could intervene and the patient could have better quality of life. But because of the financial burden to the family, and also most of them you find they're breadwinners, so they have very competitive priorities in terms of what they need. So if it's not very, very debilitating, they will not take action unless we are at mostly maybe third stage and all that. So that is a conversation in terms of how can we make it affordable. That is a conversation between the public, the private, and also NGO to see how we can make it affordable for most of the people to be able to access both treatment, diagnostic procedures, and also the medication.
So how accessible are, say, these screening services in both urban and rural areas? I understand that urban areas there's quite advantage because there are a lot of hospitals. You have the public hospitals as well from level 2 all the way to 5. We have, but in rural areas, how accessible are these screening services for chronic illnesses?
Okay, you've put it well. In the urban sectors, I think you can't go for more than a kilometer or 2 without getting a hospital, a clinic, or something. But in the rural areas, especially the marginalized areas, even getting to a facility will take you more than 1 hour. Means of transport is also a problem. But I believe if somebody wants to get something, they will get it. If they need the help, they get it. It's not accessible, yes. It's a flex for most of the people in the rural areas. But at the end of the day, that is an area that majorly most private hospitals will be setting up because of either the number of people that they're expecting, or maybe the purchase power of the people around. So that's why we are rallying the policymakers, the government, to ensure that at least there is access even to those levels. Also in terms of diagnostic, yes, you can access a hospital. Most of them are at a level 2, level 3, where you find the diagnostic tools are not available, or either the personnel to do the diagnosis is not there. So you find they have to be referred. For example, we had a camp in Kitui, and we're having very simple cases of just a CT scan, and somebody has to travel all the way from Kitui to come to Thika for a CT scan. So that calls for action for both the public, private, and also the NGOs. Yeah.
Speaking about sometimes the referrals to these, say, level 2 hospitals, so our general practitioners and, say, just doctors in general, trained adequately to identify early signs of these chronic illnesses, or do we solely rely on specialists to come and do this for us? Are you better trained in the country, and are you many to handle these cases?
Yes, I could say yes. Because remember, in as much as we do the theoretical training, the hospital, the practicals is part and parcel of training when in medical school. And you start as early as you're in school to do the rotations in the hospital, and also you're placed for a whole year in a very active hospital to be able to practice your expertise better. So yes, we're well trained. As a GP myself, I could say I'm well trained to be able to pick up some of these issues. Some of them are very straightforward. When you talk about hypertension and diabetes, they are straightforward, but others require more expertise, and that's what I said, high index of suspicion to be able to pick up some of these early signs, especially like autoimmune. Autoimmune are very tricky. Today, patient comes with joint pain, tomorrow comes with stomach issues, tomorrow things that are not ending, and you have to think, beyond what you're trained that this, I might be dealing with something beyond just a stomach issue, a joint issue, and then referral, adequate referral, refer appropriately, so that you don't refer to the wrong specialist, then the patient is derailed with the wrong specialist for a while, then you have to be referred again to another specialist. So I believe the doctors are well trained. I think it's just of resource mobilization just to enhance even the diagnostic. So we don't fully rely on labs. Actually, labs are just a confirmatory mechanism for most of the cases. As we say, when you're trained, 80% of your diagnosis comes from history taking. Me just talking to you, understanding what has been happening, taking your family history. That's why most of the people, when they come to the hospital, nasemanga tunauliza maswali kama za maternity. Now we're trying to get the history for us to come with the most specific diagnosis, so that even when I'm sending you to the lab, I'm not sending you for unnecessary tests that might not really help me with the diagnosis. And even when we're practicing, you find most of the time the doctor does not start with the lab. They don't start with imaging. We start by questioning, and then we come up with a probable diagnosis according to what you've told me. Then from there, I continue with confirmatory tests, that is lab diagnostic and all that. Yeah.
But you're talking a lot about hypertension and diabetes. So perhaps are these some of the most common chronic illnesses that you're dealing with right now in the country? Because I know you work at Maya Kidney, and I'm wondering, I'm not hearing about kidney much. Is it hypertension and diabetes?
Yeah, because majorly kidney issues and heart issues are not, mostly they're not standalone diagnosis. They're always secondary diagnosis to a primary diagnosis. So the leading NCD right now is hypertension. And you find most of the people, actually less than 15% are aware and are actually taking care of themselves. More than 50% you find they're not aware. It has been mentioned maybe in a visit 1 or 2 that they have hypertension. The second one is diabetes. We have cancer. Right now we're seeing also an issue with psychological issues, that is depression, anxiety is in the high rise. But the leading to majorly diagnosis and hypertension and diabetes, because now without proper monitorings and follow-ups, we now culminate to the kidney issues, because hypertension will lead to kidney issues, diabetes will lead to kidney issues, and also heart issues, stroke, nerve issues, and all that. That's why we're putting a lot of emphasis. That's what the major percentage of these NCDs are, and then the rest will come along. Yeah.
So when should somebody come to these health facilities to seek for, intervention from a medical practitioner? You mentioned something about people should be checking up annually, but say the signs are already showing. Before it gets to that point where this cannot be controlled anymore, when should somebody now come and seek for the health facilities? In terms of the signs that somebody should be looking out for and say, no, this one, I should now go to Daktari to ask for help.
The major sign that we get mostly are these headaches. Every time you have an receding headache, that mostly early morning, evening. That's mostly a sign of hypertension. Then, for example, for diabetes, you find that you're losing weight. In as much as you're eating, you're losing weight, and you're not understanding unexplainable weight loss. That's the same. It can be diabetes, can be cancer, or any other, or any repetitive. Anytime that you go to a hospital and you're treated for the same thing over and over 3 times in a less than 6 or 1 year. We're not talking about flus, because flus are common. Then you should be able to go a step further to investigate what you're dealing with. Any symptom that is very persistent for more than 3 months, you should look at. And also a second opinion is important, because you find somebody has been going to a level 1 or a level 2 hospital with the same issues over and over. They have even become doctors of themselves, so they know, nikisikia hii, I just rush to the pharmacy and get something. So if you're dealing with a symptom for over 3 months and so, it's calling for a next step to find out what is the problem. Yeah.
So what are some of the most misdiagnosed chronic illnesses in the country from where you sit? I know you've handled most of them, you're in that field. What are they? in details?
Hypertension and diabetes are straightforward because I'm just taking your pressure. I know the ranges, I know when it's high, sugar the same. But when it comes to cancer, cancer is one of the most, cancer and autoimmune, we're talking about lupus and the rest. They are highly misdiagnosed because you find you start at a level of GPs and also at a level of level 2 hospitals where we don't have enough. Even the lab tests that are done for them, most you find them in class E and higher in terms of labs. So you find, and that's what I said, especially for stomach cancer, utapata, somebody has been going to the hospital over and over and they've been treated for something called gastritis for even 2-3 years. Then later to find out that they've been struggling with colon, with gastric cancer and all that. And when it comes to autoimmune issues, autoimmune are very unspecific. One day you present with a headache, tomorrow you have joint pains, tomorrow you have stomach issues. So that leads to misdiagnosis. And as I said, in terms of training, we are trained about high index of suspicion. That's why am I treating this? And also history taking is also important for doctors because I'll be able to pick that you've gone to 3 other facilities or 4 other facilities because of the same issue. So I need to think beyond what has been treated and see what might be the issue. So those are the major common, those are commonly misdiagnosed. Yeah, because they're not symptom specific. For example, for diabetes, ukikuja uniambia, I've been taking a lot of water, I've been eating a lot, I've been losing weight. That is direct. The first thing I'll check is your sugars. I can tell that. When it comes to hypertension, I've been having a very receding headache, even with medication. I'll be thinking the first thing is pressure. But for cancer, you come with very unspecific. For autoimmune, we come with very, and also there are also thyroid issues. They're also very specific. When you have hypothyroidism, I'm expecting your mood is changing, you're gaining a lot of weight and all that. When you're hyper, you've heat intolerance, you're losing weight, you're eating a lot. So some of them are very specific. Others, like I mentioned, you have to have a very high index of suspicion for you to dig deeper to know what is happening to the patient. Yeah.
All right, and when we started, we were talking about how this is not a globally recognized day, and why is ours on the 10th of July? Is it that these NSDs advocacies are underfunded or undervalued? Because we see a lot of campaigns around malaria, TB, HIV, but we hardly ever hear about, you know, Chronic Illnesses Awareness Day. So where is the gap exactly, and why is 10th July the choice for Kenya?
I think there has been recognition, but we do it according to some of the conditions. Specific ones. For example, we have a HIV and AIDS Day. We have a Cancer Day, different cancers and all that. So I think we just fragmented and given holidays for different number of them, not all of them. But when it comes to a general overview of the chronic illness is not something, I think it's a buzz that everybody is catching right now, to be able to focus on it holistically, just not beyond the specific field that we focus on, because we focus on the major ones that are that are really, really debilitating even in the health sector. When it comes to the day, it's just, in Kenya, we're just following a trend because with the following, it's 7 out of 10 the leading cause of deaths in terms of NCDs. So it was just a coincidence. It's 7 out of 10, so it became July 10th as a holiday. Yeah, for that.
Would you say that Kenyans really know that this day is, you know, is there for such an event, you know, to just set awareness about chronic illnesses and to encourage the need for checkups? Are we aware, and is, let's say, the Ministry of Health, because I know that the mandate could lie on their side, to just create awareness about chronic illnesses and let the public know that there's such a day?
We have a long way, because actually I was trying to look through the media to see if there's anything on the media about the day. I don't think people are truly aware of what the day is all about and what we're talking about. So Of course, it starts. This is one of the shows that will start this, and maybe we can have events like we have for other days, that we just coming together, no specific diagnosis, just a day about awareness. Because the chronic day, we're not looking at it as people who are already diagnosed with these conditions. No, we are looking at prevention, which is the most paramount to avoid some of these. So we talk about prevention, management, follow-ups, and all that. So I think this is a good show to ensure that in future that we have more coverage, we have more awareness, we have education, we have walks on the same, just to preach and also push the awareness about the NCDs. Yeah.
Your theme today is prevention is power. So let's talk about prevention. What do we need to do on a daily to ensure that we are reducing the risks of chronic illnesses?
So we start with the basic. As I said, what you eat is what you are. We start with the diet first. I'm sure maybe most people in employment have seen most of the HRs are very aware. They're doing talks in terms of nutrition, talks in terms of mental health, because that's where we start, being aware in terms of diet, in terms of lifestyle. Be a bit active. I know nowadays it's office to your car, home. Be a bit active. There's a lot to do. You can hike. You can do yoga at home or Zumba at home. We have YouTube where you can follow just a video. Just being active. Ensuring also weight. We've seen also a lot of cases in terms of obesity, and you saw obesity is one of the risk factors to getting some of these ailments. It's not a bulletproof that if you're not obese you won't get it, but it's just one of the ways that you help reduce the occurrences of these cases. And then we talk about recreation. Let's find healthy ways of having fun. Let's avoid a lot of alcohol. I'm not saying what was kunywe, to them to come for me, but there are limits, and what limits, and also the frequency of some of these. For example, the tobacco and alcohol, which are the main recreational drugs, because they also affect your metabolism, and later in life we find that you start having these issues as early as, I can tell you, even when you're doing the wellness, when you get a chance to check yourself. Hizi vitu ziko. Even in churches, we are setting up in churches, we are setting up in public grounds. You find in a week you can't miss a health camp happening anywhere. So if you have a chance, check yourself. Listen to your body. You're the first doctor before you go to the hospital, so you know what is normal for you. And if anything abnormal, don't brush it off. Always go to a doctor. Let at least end where it's not there, but at least you've made the effort to go and check out what is the problem. Because some of these symptoms occur, but they're very subtle. So you just stay with them until now they flare up to something else. So be your own doctor. Check yourself. Listen to your body. Eat right. Practice physical exercise. Avoid a lot of recreational drugs. If you can avoid, the better. If you can't, drink responsibly and in the required quantity. Sitasema ni gani, so that people don't quote me, but I'm sure they know the required quantities for a man or for a woman.
When you talk about prevention is power, and you say chronic illnesses could be something that surpasses that 3 months mark. Is cure guaranteed? Say I come that 3 months, you diagnose something at early stages. Are you able to remove it completely and declare me, healthy once and for all?
So when we talk about chronic disease, the definition is something that persists for more than 3 months and has no cure. That's why it's chronic. Yeah, there's no cure, but to some instances, you might find, we don't like giving hope, but when it comes to maybe diabetes or hypertension, sometimes you might live right, and you find that we taper down the dosage, up to a point where you can just live a healthy, you just do lifestyle modification, and you might be off the medication, but it's not a guarantee. So long as you're diagnosed, there's also the effect of lifestyle changes. A lot will change in your life for you to fit into the new to the new you. Now that is so there's a lot that you have to adjust. But in terms of cure, because that is something every patient asks. So you've told me that I have hypertension or diabetes. When am I going to stop this medication? No, there's no time you're gonna stop. But if it happens, let it be under the doctor's advice. Don't just wake up and say, I'm feeling okay, now I don't have to take the drugs. Yeah.
I understand that can be so emotionally draining for these patients. Do you perhaps take them through, say, psychological mentorship, help? Say, after you tell somebody they came just thinking they have malaria, but now you tell them they have diabetes or maybe have hypertension. What available resources do you have for them to just help them live a normal life and not feel stigmatized or, you know, that feel like they're dying?
So that is, in terms of the healthcare ecosystem, that is a shift that we're seeing. There's a change in terms of how do we manage these patients. Because Kitambo was like, you have hypertension, shika hizi dawa enda umeze. I've not even told you what is hypertension, what are the complications, what are you expecting, what are the changes that you're expecting. So in that ecosystem, in the healthcare ecosystem, we're bringing about a program that is very unique, and that's what we're doing with Maya Hospital. It's called the Chronic Care Management Program, that ensures that in as much as you have that diagnosis, we are taking care of you holistically, not only medication therapy. So when you're diagnosed, the first thing we do, it's so hard for you, even for me, for somebody to tell me that I have to take that pill in the morning or twice a day for me to stay alive. What am I expecting? When I don't take that pill, what happens? So that is something very emotional, that now you have to change your lifestyle, you have to adjust your diet for this. So for us to take care of this patient holistically, under the chronic care management program, we are bringing in multi-sectoral approach for these patients. So from the GPs to the specialist, all the way to the nutritionist, because it's part and parcel of management. Psychosocial support is also important, because I want to be able to adjust emotionally that this is my new normal, this is what is going to happen moving forward. And also the physical aspect, because physical exercise and all that is part and parcel of that. So I know most hospitals have caught on to this, and they're setting it aside like a different program for those patients. That's to ensure that they are well taken care of, they're educated, because the first thing is education. Now I have diabetes. What is diabetes? What is my complication? What if I go low? What if I go high? What am I expected to do? What other changes do I need in my lifestyle to be able to fit into the new normal? So at Maya, we have a program for that, chronic care management, that ensures that the patient is taken care of holistically. Yeah.
I'm looking at the country's 5-year plan of NSDs that is running through 2026, and of course it aims to reduce the number of chronic illnesses, or the increasing number by 2026. Do you see us getting to that point where we are talking less about chronic diseases being on the rise? Come next year, because the 5-year plan is ending next year.
Next year. There's still an increase, because the changes that are causing the increase are still constant. So it calls in, it's a call for action for public, private, NGOs to ensure that there's proper patient awareness. From, as I said, the annual checkup, the wellness, the camps, those are things that we're using to drive awareness, that if I find you with a high, just slightly high, I have the responsibility to educate you that if you don't take care of this and this and this in terms of your lifestyle, in the next maybe 1 or 2 years, you'll be fully fledged dependent on medication. So there's still no increase. There's a lot of advocacy and awareness that is required for us to be able to bring the numbers down. But I'm sure, because there's already an initiative, we're going to start seeing changes, but not at the moment. It might take time. Yeah.
Let's talk about caregivers as well. You know, usually we just talk about these patients who come in, they have diabetes, they have cancer, they're going home. But do you also offer, say, support, psychological support, advice for these caregivers on how they're going to handle these patients? Because we understand that chronic diseases are lifetime. They're going to be with these patients for life. Do you take them through a certain training?
So that is a shift in terms of how you treat a patient, because most of the time we focus on the patient alone. We don't look at other aspects and other parts of the patient, because yes, I'm diagnosed, I'm diabetic, but my family is also affected on the same. So how do I bring in the family, either the husband, the kids, to understand? So most of the clinics, most people are accompanied, but we are seeing that in extreme of ages. If they're elderly or if they're young, they come with their caregivers. But I think in the shift of the chronic care management programs, that is something that we're trying to bring together so that we ensure the family is aware what is required, how this patient will interact with them differently, how they're going to treat the patients, because also you don't want them to feel like now the whole family has to look and take care of me. They feel like a burden. But there's a way along the program you're able to bring in other people, explain to them how the patient is, how the condition is, how to take care of them even when they're at home. And also, most of the people that are around you are the ones who are going to pick when your sugars are low. Watakwambia wewe sugar yako iko chini. They're going to pick when you're high pressure, when you have high pressure and all that. So that right now we're doing it from the levels of webinars, health talks and all that. Like whatever we're doing right now is one of it, just to create awareness. But I also feel like it's also important that in the programs that we have a segment that we bring in the caregivers, people around the patient, to make them understand the conditions better and how they can help the patient take care of themselves better. Yeah.
We've also had cases where men have been reported to have, poor health-seeking behavior, especially when it comes to HIV, going to, just for testing and whatnot. How about chronic illnesses? Are they coming more for these checkups? And let's look at it from the gender perspective, between men and women. How is the health-seeking behavior like when it comes to chronic diseases?
Of course, when it comes to gender, even in the hospital statistics, you find more women and children seek for services unlike men. And most men, for them, even when you're doing the awareness and the annual checkup, you pick some of these cases, but it takes a long time to be able to convince a man to start taking care of their pressure, sugars, or any other thing that you're going to pick, maybe high fats and all that. There's still a lot in terms of change in their perspective of healthcare. And I believe when you see a man in the hospital, just know it's very serious. Like it's something that has really affected their day-to-day lives. Men can live with the symptoms forever. So long as it's not affecting their work, they're able to wake up and move on with their day. They can still go on until it's very, very debilitating. And like for women, even a simple headache, even a simple rash, they are already in the hospital. So I think it's more of awareness and showing the patient the importance of why should I seek services why should I even see my doctor even if I'm not sick? Because I think most people visit their doctors only when they're sick. And as we insist, as we're doing the change of healthcare seeking behaviors, you're looking at having a family doctor. This is something that has been practiced in the West, and it's very effective because your family doctor is not only your doctor, that is your friend. You talk to them about anything that is happening to you, and they're able to pick some of these issues as early as they happen, and they're also easy to convince the patient that now it's time for you to start taking steps towards this, towards it. So it needs awareness, even in the gender, in the gender area. There's a lot of awareness that is needed. Yeah.
But when you talk about sometimes these men, they come when it's already too late. And we said at the beginning that 27% of deaths in Kenya are from these NSDs. And of course, a lot of hospital beds also, a lot of people are there because of these chronic illnesses. So do you see the rise in men because, they wait for long before coming to seek for this health interventions, or are women the lowest number in these hospitals?
Of course, also because of when you look at even the population, women and children are more. So even in this health-seeking behaviors, women and children will still be more because population-wise we are more. But for men, the best thing with men, when they put their mind to it, they will do it. When they get it, that's why I'm talking about awareness. Yes, found out that your sugars are high, your pressure is high, or you have early signs and symptoms of thyroid issues. How do I deliver the news to you? Most of the time, I know that the doctors end up scaring the patient because they're like, if you don't take care of this, you're going to come back with kidney issues, you're going to come back with heart issues. But I think that awareness and just using simple language to explain to the patient. Most of the time when I'm talking to my patients, even about simple issues, I just tell them in simple language for them to understand, how is this going to affect me? How is this going to cause the complication? Because ukiniambia niko na pressure, then uniambia kidneys, I'm like, they're not related. How is that going to come about? But when you explain to them in simple language, avoiding the medical jargon, for them to understand what is going to happen in the future, then we can see a shift. I see a shift, and they will look for you. And the issue with the healthcare system is you find, today I've come to the hospital, I've found Dr. So-and-so. Tomorrow I come, I find another doctor. Because of the shifts and all that, most patients don't like that, because I don't want to come and start afresh and start explaining a story that I gave another doctor the other time. So I believe that's why I talked about the primary doctor will help create a shift in that, because treatment does not start with medication. Treatment starts with trust and rapport. You understand each other, I understand you as a patient, you understand me as a doctor, and that's where treatment comes. And it's so easy to give instructions and patient to heed instruction if they trust you and if you've created a rapport with them. And that doesn't come when you're changing practitioners from doctor so to so to so to so. It doesn't create that trust. Because at the end of the day, I talk about how we deliver information. We can be told one sentence right now, and you'll be told to deliver it to 5 people. The way you deliver it is so differently. The same case with healthcare. The way you deliver the message is different from the other doctor, is different from the other doctor. And that disparity is what patients are looking for. Just a disparity in a statement. They're like, madaktari hawaelewi. And then they stop looking for healthcare. They feel like there's no connection or things are not adding up. So that is, in terms of primary health care doctors, that will help change the shift in terms of care. Yeah.
How do you handle a patient who has, say, chronic illnesses, not one, but say multiple ones, say diabetes is there, heart disease is there, let's talk even about kidney failure is also there. How do you handle that?
So that is a patient that needs multi-department management. You can't handle, you find that you can't handle that patient alone. So the way the program is set, even for Maya Hospital, is ensuring that you have that primary care doctor, that is a GP. A GP is your friend who will work with you. So they know Monica has diabetes, she has a kidney, she has kidney failure, she's on dialysis, she needs dietary advice, she needs psychosocial support, and also she needs physical support. So it's me as your primary care doctor. That's why I was saying we need a shift in the healthcare ecosystem, that me as your primary doctor ensure that you've met all the requirements for your follow-up. So if you need to see a diabetologist, I'm the one to talk to you. You need to see a diabetologist. You need to see your psychologist. You need to see your nutritionist. You need to see all that. So that can be managed if you have one doctor that is able to bring cohesion between all the departments. Yeah.
Does that make treatment more complicated in treatment if you're looking at it? Dealing with, you're talking about, it's not one doctor.
Yeah.
Does it make it more expensive and complicated? Or how do they now go about it?
Definitely, there's a financial burden to that. But when you fail to follow up, you're going to spend more. And what I assure patients, when you're keen with your primary doctor and you work together, you find that, for example, if I have diabetes and my sugars are controlled, my control metrics are matching up. maybe you find out that you see your diabetologist maybe once in 4 months, one in 6 months. So your primary care doctor will advise you, no, your sugars are okay. We can push the visit maybe for the next 3 months. In terms of psychology, also remember GPs are trained to be able to give the basic level of either psychology, nutrition, and all that. We can be able to handle this unless you want advanced. So even when you're working with your primary doctor, they can understand how your pockets are. Because if I'm sending you to a nutritionist, something that I can be able to do just to save you that amount that you can push to medication therapy, I'm sure with a good caregiver, they'll start with first training you on nutrition. They'll do the psychosocial support to the aspect where they can. And if you need further or advanced support, that's when they push you. So the primary caregiver is the one to know that how are my patient's pockets and the way option, how much does the patient need this service? Or can I wait for 6 months? Can I wait for that? So that's why I said when it comes to the program, the primary health caregiver is the one to guide you. And that is like your friend, they know you. Anajua nikimtuma on a specialist 4,000, we might miss medication. So what is the priority here in the program? Is first the medication therapy, the rest I can manage. And remember, as a primary caregiver, I have access to all these doctors. I can take your history and I go talk to a diabetologist. I have so-and-so patient, this is what is happening, what can I do? So that the program brings that. In as much as you might not have the financial muscle to go see the specialist, but I can act as a bridge to that until maybe you are able to have that financial muscle to be able to meet all the clinical. And I know financially it's crazy, especially if you're paying cash. It's when I tell you every month you have to see a diabetologist, you have to go see a nephrologist for your kidney, you have to go see a nutritionist, you have to go see a counselor. We are talking not less than maybe 20,000 in terms of consultation fee alone in a month. So the program is made in a way that your primary caregiver is your friend, will ensure that they bring cohesion between all the departments. They can do their minimum until that you really, really need that next step of care. But if there's abundance of money, why not? Let's do it all. Yeah.
But do you see a lot of these patients coming to your clinics, Dr. Say, are these patients with a lot of chronic illnesses? Not one, say we were talking about hypertension, we're talking about somebody comes in with, say, diabetes. But do you also have those who come in with all these, symptoms of chronic diseases, and now they're actually diagnosed with them? Do you have them in your facilities?
Yes, definitely. Actually, as I said, most of the patients, because of how the care is set up, they start with one. And when I'm talking to my patient, that is something I really drive. You come with hypertension, I start you with one drug. I would really, really want us to remain with one drug, if possible, because if we don't take care of you, you go to 2 drugs, you go to 3 drugs, now we go to complication, kidney and all that. And majority of the people, I can say more than 30% of the people in the program will have multiple comorbids. We call them multiple comorbids. So they have hypertension, they have kidney, or they have heart issues. Others are already at the complication level. So it's a common scenario, especially at the start of treatment. There was no proper follow-up of the patients. Yeah.
Chances of survival for people who present with various chronic illnesses. One body, various chronic illnesses. Does it reduce the lifespan and chances of, because you say sometimes there could be hope of, living a normal life and living longer. But if you're presenting with a number of these chronic diseases, does it reduce now your survival span?
No, it's not a death doom, of course, but you can't be on free mode like the rest of us. I believe even when you're doing awareness, the discipline comes in place. Because if you're not disciplined, I won't lie to you, if you're not taking your meds, you're not taking your proper diet, that I am hopeful about your prognosis. But with your discipline and you take the right treatment, the right measures that are put in place, it's not a dead doom. There are people who have this for more than 40 years. There are people who have this for more than 50 years. There are people who have type 1 diabetes and they're in their 60s and 80s. That is diabetes that was diagnosed maybe when somebody was only 5 years. So it's not a death sentence. all you have to do is heed the advice that you're given, and also the discipline in terms of the diet, the physical, and all that. And I'm sure you're gonna live well. It's just a new normal. It's just the same way that even in our lives, things keep on changing. Whatever your priorities on your 20s are different in your 30s and all that. So it's just changing your mindset and your perception in terms of how you're dealing with yourself. Yeah.
So Monica, what would you say are some of the things that as the public and Kenyans we need to unlearn about chronic illnesses? Because I understand there are a lot of myths, misconceptions surrounding chronic illnesses. What would you say from your practice that you've heard, you've seen, that we need to unlearn?
So majorly, most of the patients when you diagnose them, they will tell you, sitaki kuanza dawa sababu sitaianza. That is one of the things. Nikianza sitaiacha. Okay, there's some truth in it, but if we don't start, we're gonna start you on more medication. So and then there's the aspect of, especially the men, most of them who I see, like, mi nikianza hizi dawa, my performance will go down. That is something that I pick from other people. No, it's not. It's the performance won't go down. And then there's the issue of now the prognosis, like if I'm diagnosed, my life is done. They're looking at 5 years, 10 years, no. That is, and then there's in terms of diet, I can't eat this, I can't eat this. Those are just things that you adjust. I believe in every chronic disease, it's just adjustment. We're not stopping anything. Yes, there is the introduction of new things, but also the adjustments. So people, especially for men, they're worried about the performance because of the medication side effects. Worried about the complications. Nimeanza na hypertension sasa. They'll go to kidney and all that. And then in terms of the finances, what I say, it's very expensive to manage. That is something that sanitizer could manage. Even people who are in the employment, when I retire, what will happen? Will I manage to buy some of these drugs because they're very expensive? So those are some of the issues that you find. And I think the journey, so long as you start walking the journey with somebody who understands you, you'll realize it's not that bad. You can hack it. Yeah.
How about for people who are financially not capable? Dr. I know we talked about it, and you said sometimes people go for these harambes, fundraising, but that could be for, say, to come for this test and just for the start of medication. But what happens now, because this is a lifetime thing, how do they now handle that? Lifelong, they're financially starved. Do hospitals now come in and say that we'll be treating this patient for free? Have there been such instances?
Not really, case by case, but you can say that that is something that is sustainable for hospitals, especially private facilities. But I know for some of the NCDs, especially TB and HIV and AIDS, they are well taken care of, because those are things that we started rallying about and creating awareness and advocacy and also increasing access. And I think it's just because of the way they're infective, so they affect other people. But when it comes to the rest, in terms of care, that's what I said, you walk the journey with a doctor who understands you. Because in terms of also care, there's tiers of care, medication also. So unapata, when you're employed, you're on a medication that is worth 10,000 every month, which you might not really afford when you when you retire, or maybe you're not financially okay. There's medication at every level. Kuna hata dawa utanunua ya 300 shillings that will last you for a whole month. And there's somebody else with the same condition and they are managing it with 10,000. There's somebody else who's managing it with 20,000. It's just understanding where you are. And as I said, most of the doctors we are trained not only to look at the condition, to also look at your finances. Because when I give you that prescription that will cost you 5,000, and I know even you struggle to pay for my consultation, it will also be a challenge for you to buy. So I believe the healthcare system and the doctors are aware that you're not only treating the patient, you're also treating what is beyond that, what is sustainable for the patient. So, but in terms of free services, yes, there are those cases that they get free, especially during camps. And I tell people, if you're struggling, if there's a free camp, go there. Most of the time you find they come with those medication. You can get 2 months or 3 months worth of medication, but you don't have a system that it's fully waived, that they can get services for free. Yeah.
So say the condition has already been established. How often should they go for review after, of course, the first session you've had with them, the second session you've had with them, you've already given them the medication that they need to be taking? How often is the review? Because checkup, we say it's annually for checkup, but for somebody now with a condition.
So that is case by case. It depends with how controlled are you. For starters, when you're starting, we do it 2 weekly so that we see the effectiveness of the drug. Remember, also with the medication, there's dosages and you keep adjusting depending on how you're responding to treatment. So for starters, 2 weekly or even weekly. There are people who come in hypertensive crisis where you're like, if you continue working, you're going to come back with a stroke. So it's case by case. You find patients who are on weekly follow-ups, 2 monthly follow-ups, even 6 months follow-up. You're given a prescription for 6 months that you can use anytime, anywhere for 6 months. So it's not cast on stone. It depends with how the patient is responding to treatment and also the discipline aspects. Are you following your diet guidelines? Are you following your physical guidelines? Are you also adherent? Because there are those people who unapea and come 3 days, I forgot to swallow, so I had this and this. So it's case by case. Yeah, but for sure there are people who don't even go for their clinic for 6 months. So long as you're disciplined, you're adherent, and you're also following the guidelines, the lifestyle guidelines, and also checking yourself. And of course, they're well educated. They know when this happens, especially for people who have stayed with it for more than 5-10 years. I know myself, najuanga ikiwa juu, I know when it's slow. So for starters, it's a bit expensive. We have to really cluster the visits. But later on, once we get adherence and all that, you're hitting your clinical goals, you can go as far as even 6 months. Yeah.
So as you mark this day, the Chronic Disease Awareness Day, and as we wind up, what message would you want for Kenyans to know in regards to, chronic diseases? So
what I would say, it's not a death sentence. It's preventable first with some of the lifestyle changes. And when it's diagnosed, follow-up and monitoring is also important. And I would urge, don't wait to visit your doctor when you're sick. Make the doctor your friend. Visit your doctor. Let's get to learn and to see some of these issues as early as possible. Let's get them, let's do the adjustment, because these are cases that we find out, and when you're listening to the history, somebody tells you, I was told 2 years ago the pressure was high, but I never followed up. So if something is picked incidentally or during a checkup, please put the effort to follow up and ensure that you fully recovered or the adjustments that are required are made. Then secondly, for the healthcare system, I know this is something that we've been dealing with, but this is a special program that is important for us to focus on to ensure that there's prevention, there's management, there's follow-ups to ensure that we are not going to complications and all that. And the best thing with right now is technology. We're using a lot of technology, remote monitoring, telemedicine, which you're also practicing at Maya Hospital in the program, that you don't have to come and see me every time. You can just be a telemedicine call, remote monitoring at home, just to make the healthcare very accessible, because it's very tedious for you to just come to the hospital every month for a visit. And then using the technology in terms of machine learning and all that, we are able to follow the trend so that we can tell the prognosis, or we can tell when it's advancing to complications. So let's not wait until when it's too late. Let's make the doctors your friend.
And it's not a death sentence.
And it's not a death sentence.
All right. Yeah. Thank you so much. That is Dr. Monica Wanjiru. Thank you for coming. Dr. is a general practitioner at Maya Kidney and Health Hospital, speaking to us about Chronic Disease Awareness Day. And once again, this is a day that has been set aside to advocate for better healthcare access, raising awareness about chronic illnesses and supporting those living with chronic health conditions. Let's take a break at this point. We're coming back with Fitness Thursday.